Thank you, everyone. I'm going to move us along and thank our public comment speakers for joining us today. We're about to begin oral public comment. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For our speakers today, we have a limited public comment period. In order to make it through all the list of speakers, we ask that each speaker limits his, her, or their remarks to 3 minutes. We do have a timer displayed on the screen, so you know how much time you have left. I also want to just highlight that while we had, well over 130 people who requested to speak, I don't know if we went long over or what happened, but we have one public comment speaker with us today, and we very much look forward to your comments. So I invite Dr. Melanie Matthew to please go ahead and provide public comment.
Hi, thank you so much. Good afternoon. My name is Dr. Melanie Matthew. I've published and worked in the field of immunology for over 2 decades. Very quickly, for disclosure purposes, I am a founder of a company, but there's no financial interest in the outcome of the decisions made today by ACIP. For the last 3 years, I've used social media to teach about the SARS-CoV-2 virus, vaccinations, variants, and communicate many of your guidelines to hundreds of thousands of people. So I'm delighted to be here today, and I'm very heartened to hear all of the recommendations for universal vaccine rollout. That is what I'm here to talk about. I really feel strongly that all people of all age groups for which the FDA has approved this vaccine have access to this vaccine. There's been a lot of discussion about children today, and I understand that the data pool is not what we would hope for there. However, children, although they do suffer from less COVID-19 morbidity and mortality, there are numerous examples of lifelong morbidities associated with SARS-CoV-2 infection in children, including higher rates of higher rates of new onset type 1 diabetes, and numerous case studies showing significant cardiac issues, including necessitating pacemakers being placed in previously healthy children, all post-SARS-CoV-2 infection. And as long as this vaccine is deemed safe, I do not understand why it would be withheld from that population when it could have a significant impact on lifelong morbidity and allow a child to live a healthy life. We also tend to forget that children do not live in a bubble. They're often part of multi-generational households. They see teachers daily, and protecting children from significant bouts of infection and reducing duration of infection also protects people writ large. I'll make 2 more brief comments. I actually don't see the timer, so feel free to cut me off. But COVID-19 sequelae is significant, and it's correlated with severity of disease. And severity of disease, we know well, is reduced by vaccination. Post-acute sequelae from SARS-CoV-2 also shows up not after 1st and 2nd infections, but often after 3rd, 4th, and 5th infections. There is literature evidence that damage accumulated from SARS-CoV-2 infections is cumulative with each infection. So although many people have been exposed to viral antigens through vaccination, infection, or both, you can see physical damage being cumulative in the population, and increased mortality 6 months out has been also demonstrated in the literature. So we do know that vaccine protection wanes and can be significantly eroded by changes in the spike protein.
15
so
seconds.
Again, oh, sorry, am I over?
Just 10 more seconds. Please go ahead.
10 more seconds. All right. Well, thank you so much. I just wanted to say that I think it's abundantly clear that we need updated vaccines on a yearly basis at a minimum. And it would be unprecedented to restrict access to an approved vaccine that limits potential lifelong illness and disability.
Thank you for your comment. Appreciate it. I'm sorry you could not see the clock. We will I would just want to thank our public comment speaker, and also thank those who take the time to submit written public comments via the CDC docket. We had over 15,000 written submissions, and certainly have heard the voices of the public on the issues at hand. With that, we are going to move to our vote section of the meeting. So I'm going to ask our colleagues in the room to please put up the proposed ACIP voting language that is up for vote. So any other questions, clarification, comments people would like to make before proceeding with the vote. And I will remind my colleagues that we do need to put our screens on for the vote. Yeah, I don't see any hands raised, but I am seeing screens. So thank you everyone for joining. There might be a few others who I think are in the middle of clinical services. If you're able to join us on screen, that would be wonderful. Okay. Well, we will go ahead and it's been moved and seconded that we accept this vote language. So I don't see any additional hands raised. We'll go ahead and I will call on individuals to please vote, and please remember, state your name, whether you have any conflict of interest in your vote. We'll start with Dr. Bell.
Beth Bell, no conflicts, yes.
Thank you. Dr. Cotton?
Meal Cotton, no conflicts, yes.
Thank you. Dr. Long? Okay, we'll come back to Dr. Long. Dr. Sineas?
Sybil Sineas, no conflicts, yes.
Thank you. Dr. Lair?
Jamie Lair, no conflicts, yes.
Thank you. Dr. Paling?
Kathy Paling, no conflict, yes.
Thank you. Dr. Sanchez?
Pablo Sanchez, no conflict, no.
Thank you. Dr. Talbot?
Dr. Talbot, no conflicts, yes.
Thank you. Ms. McNally?
Conflicts, yes.
Thank you, Ms. McNally. Dr. Daly?
Matt Daly, no conflicts, yes.
Thank you. Ms. Bata?
Lynn Bata, no conflicts, yes.
Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Thank you. Oh my goodness. Okay. Dr. Long?
Thank you. I'm sorry, I had some noise going on here. Sarah Long, no conflict, yes.
Thank you. Dr. Chen?
Wilbur Chen, no conflicts, yes.
Lee, no conflicts, yes. Are there any members I didn't call on since I went completely out of order? Okay. Dr. Wharton? I think I have 14 yeses and 1 no.
Well, 13 yeses and 1
13.
no. There are 14 members of the committee.
Thank you. Thank you. So the motion passes as proposed. And with that, we will open up for comments from our voting members as well as our liaisons if they wish to make any public comments about the vote. So Dr. Talbot, I see your hand is raised.
I have two couple quick comments. I'm going to reinforce vaccines for adults over and over and over again so we can get rid of this inequity and improve vaccination rates for all adults regardless of age. The second thing I want to highlight is something that Dr. Daly mentioned, is that we are still learning about COVID, and this data is going to change all the time. And so I think we need to constantly reevaluate. We actually don't know when the COVID season is. So fall may not be the time for us to be voting on and recommending vaccine. It may be spring. So I just want us to remember that and to reevaluate continuously and vaccines for adults. I'm done. Bryce, you're on mute.
Thank you. No wonder why Dr. Sanchez couldn't hear me.
I was wondering if I was next. No, as voting against it, I just want to be clear that I am not against this vaccine. The data do look great. The limited data that are available does look great, even though it may not be the most the circulating variants currently, but it has neutralizing activity against the other variants, and certainly the ones that are circulating now or expected to be circulating. I I am very much pro-vaccination and certainly high-risk groups. I just want to comment that we have extremely limited data on children and infants and other individuals, and so I think that needs to be made available then to the parents. And I also think that in certain circumstances, we do have to be concerned about potential side effects, especially in the in young adults and young adult males. And so I think all of that needs to be weighed. And so that's why I hesitate to make it just a universal recommendation, even though I do support vaccination with the COVID vaccine. Thank you.
Thank you. Ms. McNally?
Thank you. I really just want to emphasize for consumers that it's very important as they consider this particular vaccine that they talk with their healthcare provider to make sure that they have all of the best information possible to make a decision to protect themselves against this circulating strain and other strains of the COVID-19 virus. Thank you.
Thank you. Dr. Lair?
Thank you. My office staff just asked me, and I think it's probably useful for the entire country to now be reminded that the bivalent vaccine is no longer recommended. And so it should not be given and should be taken off the shelves and put to the side. They were thinking that they were going to be giving it until we got the new one in, but I understand that by this vote, we're recommending not to use the bivalent vaccine anymore. So that's important for all the offices in the country. Thank you.
Thank you. And then just to clarify, I think from the FDA authorization yesterday, the bivalent vaccine is no longer authorized by FDA. Thank you. Dr. Duchin.
Thank you, Dr. Lee. I just have a brief statement on behalf of the Infectious Disease Society of America. IDSA supports that ACIP's new recommendation makes COVID-19 vaccines available to all persons 6 months of age and older who choose to be vaccinated. Most importantly, we strongly encourage the updated 2023-2024 vaccine for all persons who are at increased risk for severe COVID-19, including everyone 65 years of age and older, and the many, many, many adults under 65 years who have one or more underlying medical conditions that place them at increased risk for severe infections. Thank you.
Thank you, Dr. Duchin. I don't see any hands raised. Last call. All right, well, with that.
Oh, I'm sorry. It's Dimitri Daskalakis. One very quick last call. So I just wanted, I apologize. It's the hand mic and our speed in turning it on. I apologize. So first, I want to just say thank you to everyone on the committee for all the amazing work and just a really rich discussion. I think this is sort of where the magic of ACIP is, that after all of the thought and all of the discussion and such a clear process to go from data into recommendation, it's so inspiring to see the process and to hear the voices and to hear opinions in all directions. And I just also want to give a very specific and loud shout out to the NCIRD staff that works so hard to make sure that all of this magic happens and supports ACIP and all the work that they do. So I think that just thinking about the importance of this discussion and the importance of the decision in protecting Americans from severe manifestations of COVID, this process, its transparency, and just the amazing thought and work that has gone in from every direction is really inspiring. And I don't want to keep you anymore from the rest of your day, but I just wanted to once more say thank you so much for all the amazing work.
Thank you for those comments. And I want to just echo my thanks to all of the speakers and all of our ACIP ex officio and liaison members for your work today and for your ability to come together for somebody's going to count for me, but I think our 34th meeting since the pandemic. With that, by some miracle, we have ended on time. So I thank you all for your efficient, thoughtful, robust discussions around this issue. We certainly appreciate it. And I know the public appreciates being able to hear the deliberations. That this is not an easy decision, but one that has been really at least well considered from all different angles about how we get to the decisions we do. So thank you again. We look forward to seeing you soon. Have a great day.